Welcome to RA Online. Today's topic is epilepsy surgery, and it will be dealt in a series of lectures, and this is the first of that series. The outline of this series will be including definitions of epilepsy and seizures. Then we move on to classification of various types of seizures, and then we'll move on to how to clinically approach a patient who's having epilepsy. And then finally, if the candidate is fit for surgery, how do we preoperatively evaluate such a patient? Seizures are the most commonly encountered neurological entity. Nearly 1% of Western population have epilepsy. This is data mainly from the US. Acute, symptomatic and unprovoked seizures are most commonly neurosurgical candidates, and nearly 2/3 of patients with epilepsy may not achieve freedom from seizures with anti-epileptic drugs, and many of these patients may have a disorder that can be treated surgically. So, these are the reasons why epilepsy is picking up as a surgical subject rather than a neurological one nowadays. Given that whooping 70% of patients with epilepsy may not achieve freedom from seizures with anti-epileptic drugs also. We are moving on to the definitions of seizure and epilepsy here as defined by the ILAE, International League Against Epilepsy. So, the conceptual definition of seizure is one where epileptic seizure is a transient occurrence, where it occurs for a minute or a few hours also, and it will be in the form of signs and symptoms due to the abnormal, excessive or synchronous neuronal activity in the brain. So, whereas the definition of epilepsy is a much broader term, where it refers to a disorder of the brain, and it is characterized by an enduring predisposition to further seizures, and it's also characterized by neurobiological, cognitive, psychological and social consequences of this condition. So, the definition of epilepsy requires at least one epileptic seizure occurrence. Moving on to a more practical definition, or what we use operationally as in practically in day-to-day practice, is that epilepsy is a disease of the brain where the patient should have at least 2 unprovoked or reflex seizures, and these should have occurred at least 24 hours apart. If the patient has had only one unprovoked seizure and has a probability of further seizures similar to the general recurrent risk, which is around 60% after 2 unprovoked seizures over the next 10 years, these 2 patients you can consider to be having epilepsy. And epilepsy is considered resolved in individuals who have crossed the time period, the applicable age for something like febrile seizures, which usually resolve by 5 years of age, and also those who have remained seizure free for a period of 10 years, and those who have not been on AEDs for the last 5 years. So, how have these definitions come up? So, the probability of a patient who has had a seizures over the next 5 years is around 30% when the patient has a normal EEG, a normal neurological examination and a normal neuroimaging. However, this risk goes up, or the probability of seizure goes up to 56% when the patient has an abnormal EEG or an abnormal neurological examination and neuroimaging. If this clause or becomes and, the probability of seizures increases to further 73%. The patient has an abnormal EEG, abnormal neurological examination or neuroimaging, the probability of seizures increases to 73%. So, any patient who is having a seizure risk of more than 60%, that is what a patient with 2 unprovoked seizures would have over 10 years, then that would mean these patients, even though they would have had only one seizure episode, they are likely to have a epileptic disorder. So, therefore, it is possible to make a diagnosis of epilepsy after a single seizure episode, especially if the EEG, neurological examination, neuroimaging are available and any of these 3 are abnormal. All patients with a first unprovoked seizure should have a careful neurological examination, at least a routine EEG and neuroimaging, which is preferably a magnetic resonance imaging, to ensure that this patient with a seizure is not having epilepsy. Other factors for increased risk in seizure, which should also be considered in defining a patient of whether having epilepsy or not, is that if the patient has first had a seizure during sleep, or the patient has a family history of epilepsy and or a history of febrile seizures. Patients with moderate to severe traumatic brain injury have the risk of developing seizures even up to 10 years from the time of the trauma. So moving on to classification of epilepsy, this again is given by the ILAE classification, and they came up in 2017 with a very simple classification system through these two position papers in 2017. The purpose for this classification is for getting to a clinical diagnosis, and this clinical diagnosis should be in a transparent and universal language, and we should be using words that mean what they say. And by that I mean that they are mostly self-explanatory terms which most medical personnel will come to understand, and not use jargon which is understood only by epileptologists or epilepsy surgeons. So moving on to this classification, basically this 2017 classification defines 3 seizure types, one which has focal onset, one which has a generalized onset, and one which may have an unknown onset. So once you know whether the patient is having a focal onset or a generalized onset, you can then further decide whether this patient is having multiple episodes of seizures, and then you can further classify them into epilepsy types. And these epilepsy types may be of monomorphic, where you can say every time the patient is having a focal onset, and it can be polymorphic, and it can be having a combined general and focal onset seizures, and sometimes they can be categorized into epilepsy syndromes. So ultimately we try to address the etiology of these seizure types, and the etiology may be structural or genetic, and in the case of provoked seizures they may be infectious, metabolic, autoimmune, or they may be idiopathic or unknown. Infectious, metabolic, immune, you treat the etiology medically, but when it comes to a structural cause, this is where the surgeon's role is very important. Once you remove the structural cause, there is a high possibility of the patient becoming seizure free, and some genetic causes we can do palliative surgery. So if the patient is having a structural cause of seizure, we can achieve a curative epilepsy surgery, and in genetic cases we can try for a curative outcome, but palliative procedures are also there to reduce the frequencies of seizures and also possibly make the patient seizure free. And all this we should consider the comorbidities of the patient, keeping that in mind. So what is a generalized seizure? Basically it's a seizure originating in some part of the brain, usually in the cortical subcortical region, and it rapidly engages both sides of the brain. So bilaterally distributed networks are there, and these are usually rapid, with the patient losing consciousness, and with this they can include cortical and subcortical structures, and not necessarily the entire cortex, but the patient since is losing consciousness, there should be a cortical involvement.